Hello, this is Siddharth Tambar from Chicago Arthritis and Regenerative Medicine. It's July 20th, 2020. Welcome to our weekly educational broadcast that is live. On this broadcast, I focus on topics related to arthritis, tendinitis, injuries, back pain, autoimmune conditions, a lot of things that we do here at Chicago Arthritis, and focusing on evaluation, treatment, cutting edge treatment, concepts, things of that nature. Normally in this meeting, I am talking to my own team at work, kind of going through issues and questions that they have, that patients have, and trying to focus on big picture principles and topics that are relevant to all of them, in particular patients, and what are their thoughts and concerns. So actually, because of the nature of scheduling today, I'm actually on my own today. Normally I have a couple of people sitting down here asking me questions as I'm kind of going back and forth. But there are a couple of things that I think are super relevant that, seem to come up quite often when patients ask about their pathology. A lot of times I get asked questions about, are bone spurs significant? When are they significant? Should you treat them? Are they causing problems? And, there is this concept in regenerative medicine about instability, that instability is what really drives and is the cause of most problems that we have in the musculoskeletal system. And so an example of that would be, you start off with some sort of mild soft tissue injury, let's say a mild sprain of an area, let's say a mild ankle sprain, and that over time, if you have either a bad enough injury or sort of repetitive injuries, you then develop some degree of mild chronic instability. And that instability is a problem because it can then lead to more stress on that joint, more tendon changes, more bone changes, more cartilage changes, and eventually an arthritic process or a progressive tendon problem, which then on its own leads to more pain, functional limitations, and problems. So instability is really the cause of so many of the problems that we have in the musculoskeletal system. So the body is a relatively nuanced and very sensible kind of organism. And if there's chronic instability, one way to try to there are a few ways that the body will try to treat that. Number one is by offloading to another joint above or below or another muscle group. Another way is by actually filling in an area of weakness. And so if you've had chronic instability in a tendon or a ligament, what you'll see is a calcification that'll develop in that area, which is the body's way of trying to improve that instability. You have an area of weakness, an area of a gap, fill that in with something that can offer some degree of stability. Reality is it's not very good stability, but it's generally the body's sort of last resort to trying to help stabilize and salvage an area. So calcifications, usually when you see them, whether they're osteophytes, meaning a little calcification off of a joint, or they're enthesophytes, meaning calcifications within a ligament or a tendon, they normally are suggestive of chronic instability in that area. And normally that does not need to be treated in the sense that that's not what's causing problems. For most people, let's say if you have, for example, let's say you've had a chronic sprain of a medial collateral ligament in the knee or a chronic sprain of a ligament in the ankle, normally that calcification does not need to be needled out or taken out. In fact, that calcification is a method of providing more stability. And so treating the instability is the way that you want to treat that, and recognizing that calcification as something, as sort of a identification that, hey, here's where there's instability and a problem. That's where you want to direct your treatment approach to that area. So that's the vast majority of calcification areas. It's not the calcification or the bone spur that's the problem. It's more a sign of a deeper underlying problem. Another example of that, I had a patient last week who has some chronic ankle and Achilles tendon issues. And while he has some degree of calcification within the Achilles tendon, needling that out is not the right way to treat that. It's treating the tendon that's been chronically injured and then treating some of the other soft tissue structures around that as well that are leading to that kind of instability and stress on the Achilles tendon. So calcifications normally don't need to be taken out or treated. They're just an identification where there's an issue. Now, there are some exceptions to that. So, for example, I had another patient last week who had chronic calcification or chronic pain in an ankle from prior instability from a prior sports injury. And I had treated her ankle maybe about 6 months ago, and she's had improvement. She has some persistent discomfort over one of the tendons over the inner part of her ankle. And on ultrasound, you can tell that she has calcification within that tendon. There's a little bit of calcification. So it's a sign that the tendon's been injured before. And we ended up treating the tendon again by injecting platelets into the tendon again. But besides treating the tendinitis, I could tell functionally based on a dynamic ultrasound that she has a little bit of impingement where that calcification is, that it's sort of preventing that tendon from really contracting and moving and gliding as smoothly as it should. And for what it's worth, she also has tenderness right over where that calcification is. So in her case, we didn't ignore the calcification. In her case, what we ended up doing was injecting platelets into the tendon for sure, but first actually taking a needle and sort of needling out that calcification. The idea being, let's get rid of this structural issue that is causing some functional limitations, that is actually causing pain in this case, and then we'll inject platelets back into that area of injury to help treat the tendon. So that's one indication where treating calcification makes sense. Another indication would be patient of mine that had calcific tendinitis or frozen shoulder, where she was unable to progressively lift her shoulder abducted, meaning lifting it to the side. And part of that is because she's had an original injury. And part of that injury process was that she developed an overcalcification process within the tendon itself. And that calcification on its own was causing inflammation and impingement of her range of motion of the tendon. So in her case, we ended up doing a treatment called Percutaneous Barbitage, where we take a needle and just sort of needle out the calcium and then inject saline or sterile water into that area and then aspirate it back out. And in that case, it's because that overcalcification in the tendon is what's really where the pathology is, and that's really what's causing her difficulty to move her shoulder. And so in that case, the calcification is in fact pathologic and needs to be treated. So part of it depends a lot on what is that bone spur calcification doing in that area. And normally it's there as your body's normal way of trying to offer stability, and taking that out is not a smart idea. It can actually make the area a bit more unstable. But if you have functional findings, whether that's on examination or certainly on ultrasound, where you see that there is dynamic impingement that's caused because of calcification, then actually treating that calcification by trying to needle it out or take it out can be helpful. It's an example of where you're combining not only clinical understanding of the pathology, you're also combining dynamic ultrasound and the tools that are available to help actually identify if it's actually causing more of a problem and if it's not just offering stability. So bone spurs can be important, and an understanding of when and how to treat it is useful. And the last part I would put is, if you've got a chronic calcification in the tendon that has to be needled out or taken out, make sure that there's then cells being put back into that area of weakness. It's not uncommon that once that calcium has been taken out or needled out, that there is then a little bit of a gap in that tissue, whether it's ligament or tendon, and that injecting your own cells in that area to help heal that injury is useful and necessary if you want to add better stability to that area, so that you don't then develop progressive instability on top of that. I hope that gives some explanation as to when bone spurs are significant and when you should treat them and when you shouldn't. And until next week, have a good day, live well, and bye-bye.